Hey folks, Keyrad Singh here again, PGY5 resident at Vanderbilt, here to talk to you today about compartment syndrome. I want you to think about compartment syndrome as a cyclical thing. You start initially with some kind of trauma to the tissue, and we'll get into the details of what that is, whether that's internal or external. The injury then leads to edema, and then the edema then leads to decreased perfusion, which then will cause muscle death if it keeps going, and then that leads to more edema and decreased perfusion, and the cycle keeps going around and around. The definition of compartment syndrome, really I want you to think about this as oxygen deprivation to muscles and nerves because of elevated pressures. And so that's the definition. Acute myoneural ischemia because of elevated intracompartmental pressure. And a compartment is sort of any area in the musculoskeletal system that's bound by fascia. And so there's only so much capability of that fascia to be able to expand. And so when the perfusion pressure starts to drop because the pressure inside the room, i.e. inside the compartment, is so high, you have myoneural ischemia. There are a variety of causes. And it's important to know about these causes because you will be hypersensitive and look for compartment syndrome in these cases and be less likely to miss them. Obviously, trauma is a big one. So sort of bigger, high-energy motorcycle accidents, comminuted segmental femur fractures certainly tip you off to the possibility of compartment syndrome. Other sort of less thought about things are post-fixation. So just because you've put an X-fix on doesn't mean you are free and clear. There are certainly compartment syndromes that occur after fixing or closing big wounds that you may have thought were kind of tight in the OR, but you closed them anyway, and then a couple hours later the patient is in extreme agony on the floor. Vascular injury. So if there's been some sort of clamping of the aorta and the lower extremities have been deprived of oxygen for a while, and then all of a sudden the aorta is unclamped after a AAA repair, for example, you then can risk reperfusion injury, which is sort of massive free radical oxygen going around damaging tissue, and particularly the basement membrane in and around blood vessels, leading to extreme extravasation and edema, which can then lead to compartment syndrome in and of itself. Other things are circumferential burns. Extrinsically, someone who's not experienced can end up putting an A-strap on too tightly, putting a cast on too tightly. And then the question always occurs is, what about open injuries? Well, first of all, open injuries are susceptible to compartment syndrome just like a closed injury. Just because you have a small, tiny poke hole in the fascia, that's certainly not enough to vent a compartment and prevent you from having compartment syndrome. So the summary take-home point there is open injuries can also get compartment syndrome. There are some scenarios of overexertion that can also lead to compartment syndrome. I didn't put that up there. And then the incidence of compartment syndrome is roughly between 6 to 9% of open tibias that are associated with compartment syndrome, which makes sense because open injuries generally tend to be high energy anyway. Symptoms: pain out of proportion. When you go to see a patient with compartment syndrome, this is not the patient who's sitting calmly at the bedside doing a crossword puzzle. This is a patient who can't get comfortable, is yelling, is all kinds of expletives, throwing things, and wants that pain to be tended to. The caution there is you may not get this kind of response from a patient who's schizophrenic, obtunded, or intubated, so you have to have a higher degree of suspicion. A word there about putting regional blocks in, certainly not indicated after any kind of fracture repair where you're worried about compartment syndrome. And some folks may tell you to avoid using PCAs because PCAs may mask this development of compartment syndrome, and the patient may self-dose narcotics to the point where you may not be able to tell. Sensory changes don't really occur until compartment syndrome's really been around for at least an hour. Nerves are very sensitive to oxygen deprivation. Muscle death occurs, roughly after 6 to 8 hours of ischemia. But within an hour or so, you're going to start to see sensory paresthesias. On your exam, any kind of pain with passive stretch will cause excruciating pain. You will hear in the literature about some of the 5 Ps, poikilothermia, i.e. things getting cold, pallor, pulselessness. By that time, things are really sort of advanced and progressed. Your job as an orthopedic surgeon is to really start to be able to diagnose compartment syndrome in its early phases and where you can go ahead and intervene. So things like paresthesias and pain with passive stretch will help you. Pulselessness, by that time, things are already fairly delayed. Poikilothermia, tissue is cold, paralysis, pallor. I want to highlight something to you, and that is studies have shown that compartment syndrome is missed more in non-fracture settings. And so it's because likely that people aren't thinking about it. So the best way to not miss it is to have it on your radar. That's a subtle point, but you're more likely to miss something if you're not thinking about it. So obviously think about compartment syndrome in fracture settings, but all the other settings we also talked about, it's important to have it on your radar. And it's ultimately a clinical judgment. We will talk about some sort of objective tests for compartment syndrome, but by and large, you kind of feel the tissue, and it's important to repeat the exam because sometimes things may be getting better or worse, and at the same time, important to document in today's medical legal world, document your exam. And when you do the exam, I'm going to give you an example of the leg. And so you can use paresthesias and the knowledge of anatomy to say, hey, which compartment may be starting to get tight. The superficial peroneal nerve runs in the lateral compartment. So paresthesias on the dorsum of the foot will indicate that something in the lateral compartment may be upset. If you've got paresthesias in your first web space, then your deep peroneal nerve, which runs in your anterior compartment, may be heralding that something is not right there. The sural nerve runs right along your gastrocsoleus complex posteriorly, and that'll tell you if paresthesias along the lateral aspect of the foot are occurring. That means think about something in your superficial posterior compartment. And deep posterior compartment has the tibial nerve, so paresthesias or abnormalities along the plantar aspect of your foot may be pointing you in that direction. Again, these are very rough guidelines. Everything is sort of a clinical assessment, and not all compartment syndrome is going to present with paresthesias in these particular distributions. Again, if you have somebody in a car accident who sustained significant trauma, they likely are going to have a mixture of all kinds of paresthesias. It's not like you're going to get isolated anterior compartment syndrome only, and you're going to be looking for just that sensory paresthesia. So use these anatomical paresthesias as guidelines. Normal tissue pressure roughly is on the order of 0 to 4 millimeters of mercury. And if you really are overexerting your muscle, it should only really rise to about 8 to 10 with exertion. So if you've got an absolute pressure of 30 in a compartment, then you know something is abnormal. More and more, we're now moving away from this absolute pressure of 30 to a measurement that is 30 within the diastolic pressure. If the diastolic pressure is 80 and the compartment pressure is 60, then you know that you certainly don't have enough perfusion pressure to adequately provide oxygen to the muscle and the nerves. And where you measure compartment syndrome is also very important. A study came out and showed that if you're outside of 5 centimeters from the actual fracture site, the compartment pressure will drop off so much so that you will actually misdiagnose them with not having a compartment syndrome. The point there, measure close to the zone of injury. When you're seeing these patients, the first important thing to do is to remove any kind of restricting bandages or any compressive wraps, and to do serial exams. Again, document them. And as soon as you actually have the diagnosis, there is no alternative to the surgical approach. You have to do a fasciotomy. And when you do the fasciotomy, all compartments within that anatomical area need to be decompressed. It is inappropriate to just go in and do a lateral compartment fasciotomy of the leg in somebody who just fell off a ladder and has a swollen leg just because you felt like their lateral compartment was tight. They may have developing compartment syndrome in the adjacent area, and muscle edema from an injury is likely to be occurring all around, not just in the area that you think you've decompressed. So the take-home point there is all compartments need to be fasciotomized. If, however, compartment syndrome is missed and it's greater than 24 hours, then release is relatively contraindicated. In those scenarios, if you end up opening up the fascia and the skin, you're going to expose the tissue to the external environment and then potentially an infection. Those folks will end up with late muscle fibrosis. Volkmann's ischemic contracture of the upper extremity is something that is classically an example of a case where you miss compartment syndrome. When you take them to the OR and you do the fasciotomy, I want to talk about aftercare for a second. You dress the muscle with sort of a non-adherent gauze. You can put wound vacs on top, elevate the limb thereafter to decrease the edema, and then you can use vessel loops to make a Jacob's ladder in and around the wound vac sponge, which will then actually help with the subsequent closure of the soft tissue envelope. And then bring them back. Sometimes people bring them back 48 hours after, a couple days after, and reassess the tissue. If the wound is clean and well perfused and adequately debrided, you can consider primary closure at that point. If you can't do that, then a delayed wound closure with something like a split thickness skin graft is also appropriate. My email is keyrat.singh@vanderbilt.edu. Should you have any questions, you can always email me. Again, some of the big take-home points here are you're less likely to miss compartment syndrome if it's on your radar. Pain with passive stretch. Increasing pain requirement is also another one. If you diagnose that the treatment is surgical and it has to be an adequate all-compartment fasciotomy, document what you see. Again, any questions, you can email me. Thank you.